If you're in your 30s or 40s and suddenly dealing with brain fog, stubborn weight, anxiety, or skin issues, you're not imagining it. These could all be signs your hormones are shifting. Today, I'm joined by Dr. Sarah Daccarett, a board certified physician with a special interest in women's hormone health and the founder of Inner Balance. In this episode, we are diving deep into what really happens during perimenopause and menopause, the science behind HRT, bioidentical hormones, and the hormonal cascade that includes estrogen, testosterone, and yes, the often overlooked superstar, progesterone. If you've felt dismissed or overwhelmed, this conversation will leave you informed, empowered, because the truth is, you're not just getting older, you're navigating one of the biggest hormonal transitions of your life. Let's get into it. Dr. Sarah Daccarett, welcome to the podcast. Thank you for joining me. I'm very excited to have you.
Thank you for having me. I'm thrilled to be here.
I want to just dive straight in and I want to talk about a hormone that seems to be kind of like the poor cousin that no one mentions and that people don't think about very much in women, and that is progesterone. And I want you to first of all, tell me a little bit more about what is testosterone and why is she so important, and how has she ended up being thought of as just about endometrial protection and about nothing else? And why have we got it wrong?
Progesterone is a woman's main hormone, actually. We talk a lot about estradiol. We talk about testosterone, and testosterone is largely getting a lot of the focus now. And so does estradiol. There's a lot of controversy around that and whether women should take it. And the progesterone is literally ignored. We ignore it. We have zero papers. We have like 5 papers in the whole world that has established optimal reference ranges in the laboratory for progesterone, for example. We don't actually know what those are. Why it's been ignored, I think it's just because hormones in general have been ignored for women. We're about a decade behind men's health. So men, we have established reference intervals for testosterone. We know how much to give him. We did this over the last decade for him. And now we're just trying to play catch up. So we need to do the same thing for women. And traditional medicine will say that progesterone is only needed in a woman if she has a uterus. It's only for protection of the endometrial lining and nothing else. When is wild because it's literally used to counterbalance estrogen in every process of the body. We need progesterone to maintain blood pressure, for brain health, for bone health, heart health, skin health, libido. Like it helps us, especially with like mood and sleep. And women very much need it for everything. And yet it's still like not even offered to women post hysterectomy. They don't even get it. Yeah, it's kind of wild how and then the hard part about progesterone is that it's actually a very big molecule, so it's hard to get into the body. And so this has made hormone replacement therapy challenging. Pharmaceutical companies and big pharma have made synthetic versions that are easier and smaller, and you can take them orally or they absorb through the skin, and that's why they've modified them. And now we have 300 types of birth control that are made out of a fake hormone that really doesn't even mimic our own natural hormone at all. And it's caused a lot of problems, and it's causing health problems, and it's practically a crisis now because of all the health problems from low progesterone alone in women. So yeah, women need to be able to recognize it as just as important as the other two, if not more important, because it needs to be in a higher ratio than estrogen and testosterone. And this is confusing. Like we can talk about why it's so confusing that women don't. Part of it's because the laboratories they report like a 1 or a 2, 3, 4, 5, 6. This is like what the progesterone range is. But that's not a number 1. That's actually 1,000, right? They just don't write the whole 1,000 because they don't wanna fit it on a lab report. So that if physicians and patients will downplay it, like, "Oh, it's not even that abundant," but it's magnitudes higher than estrogen or testosterone.
Can you explain to everyone listening what happens kind of over the span of your lifetime with progesterone? Or do we even know that?
We do. I mean, when the ovaries start to fail, which they can actually fail pretty early or they start fatiguing, they cannot make its primary hormone, which is progesterone, but they can still make spikes of estrogen, So let's say around 30. We don't really even have to define it because the problem is even if we start defining what age this is happening, then we're ignoring younger women who it's definitely happening to. But let's just say it kind of gradually starts to decline as we age because we were never meant to live till 90 and our ancestors died at age 35 and now we're having babies at age 35, right? So the ovaries were never meant to work that long. And as the ovaries start fatiguing, they can't no longer make progesterone. So the brain starts to panic. It starts releasing a hormone called follicle stimulating hormone, FSH. This stimulates the ovaries to start making hormones, but the ovaries can't. So they can't make progesterone, but they can make like a spike of estrogen. And that's where you get this roller coaster ride of perimenopause for like, oh, 20 years. I mean, it's like literally a very long time before the period actually stops. And women are told that they have to wait until the period stops. We have, and this is also really causing a lot of problems for women that they have this conception or misconception that we have to wait. And I don't tell men that they have to wait until they can no longer make sperm. Hey, you have to be no longer making sperm for an entire year, and then I'm going to give you testosterone. But we absolutely tell women that they have to wait an entire year their period stops. So, and it's because men don't have a visible sign of fertility, whereas we do. And even this is not a really good sign of fertility in itself.
And so, what kind of symptoms would you expect someone might be starting to have at those early stages when progesterone production is really beginning to stutter and struggle?
I think so any woman that's struggling should be clued in that it's a hormonal problem if she has more than one symptom. If you're just tired because you're not sleeping because of the kids, it's fine. That's like only one symptom. But generally it doesn't come with just one. And the earliest symptoms are the anxiety, depression, irritability, insomnia. They are largely progesterone related, but I would argue that anxiety and brain fog are also estrogen related. So it's you get like this erratic production of estrogen, but it's not consistent. Some days of the month, like, you'll notice that you feel okay, but the rest of the time you feel crappy. And this is like you're maybe able to make enough estrogen part of the month. But progesterone, when it starts to drop off, I would say that what bothers people the most, or women the most, are the brain symptoms. It's the mental health. We have women take in the US, the women take the bulk of the prescriptions, antidepressants, anti-anxiety meds, and, sleep aids, statins for heart disease. I mean, they're getting that prescribed that first. ADHD, like I'll hear women say that I went through my perimenopause in my 30s and now I have ADHD. And it's like, it could be ADHD, or it could just be, low estrogen and progesterone, and now you can't focus. So the mental health, I would say, is what kind of are the early signs of it all happening.
And are there any indicators that someone might experience in their periods if progesterone is low? Is there a change that you might see in periods?
Yes, but this is kind of a sign that it's getting really bad. So if women's periods get really heavy and really painful, and you can have really heavy painful period. This is not normal to have a heavy painful period. Our ancestors did not do this and, they were not scavengers or hunters or gatherers and having heavy periods. It needs to be an indicator that this is a health problem. And instead we tell women that, oh, this is just part of being a woman, or that this is normal, or maybe you just can't tolerate the periods like, your friends. But when you don't have the protection of the endometrial lining with progesterone, then you can get really heavy painful periods. And hysterectomies, they're a very common procedure. I can't remember the statistics, but I would say 30 or 40% or something like that last time I saw it. It's a lot of women getting this to treat a heavy painful period. And when it could potentially have been addressed with something non-invasive, less risky, which is progesterone.
And so, would you recommend doing lab tests for progesterone regularly, or like what would you suggest to someone listening who's thinking, oh, that's me. I'm not sleeping and I'm feeling really anxious. Should they be really thinking about progesterone levels more than anything else at the beginning, or?
The problem is the laboratory testing is not as reliable as it needs to be. Given that how far we've progressed in other areas of medicine, I would say that there's an inherent variability in hormone testing. So there's a lot of biological variability, meaning that if my hormone levels will fluctuate through the day. And then also if I were to draw a sample of blood and send it in, that every time the accuracy and precision of that sample in the lab is actually really low, meaning that I could get an answer and then run the same test and get a different answer and then a different answer. And that varies by like, 15, 20%. So this is something that women need to keep in mind, that these absolute levels are not as accurate. And perimenopause, which is this period that we're talking about, is a clinical diagnosis. It's not a laboratory one, and they need to trust themselves more than any laboratory test. They need to like turn inward. They need to know that this is changing for them and that they don't feel well. Maybe there's some tests that might be better like FSH. As I mentioned, remember when I was saying that the FSH rate gets higher and higher, it kind of slowly goes up. This could be something that they could follow over time. So I got one when I was 25 and now it's getting higher, or I'm following it over each month to kind of see what it is and is it steady. This would be a little bit more helpful for women to follow an FSH. But still, even if her FSH is normal and she has this collection of symptoms, and she should be thinking hormonal and trust that more than any lab test.
So, yeah, so I want to just clarify what you're saying, or what I'm hearing is that if we took a blood sample and we ran a test on it and we got a number, I don't know, number 3, that was the result, 3. We could run from the same blood bottle and through the same lab, and we could then get a 2.5 or a 2. And that would be something that wouldn't be unexpected. So, perhaps as doctors and as patients, maybe that we're reading into the accuracy and running by numbers a little bit too much and being led by the numbers too much.
You're right. Like we tend to rely on the subjective data more instead of our subjective experience because we're always being told that it's subjective and that, well, how do you know that your periods are heavy and painful? I mean, every possible thing like, well, how do I know you're fatigued or anxiety? You have it. And so this tend to rely, especially in medicine, on this lab value, but what people have to remember that labs are not perfect. They're also not like they're not everything. And with you have, it's not like getting a sodium test in the hospital. Like if you're critically ill, we have tests that are very accurate. They're really accurate, actually. Like if you get a sodium, it's going to be the same every time you order that test. And it's very clinically accurate. So it helps physicians make decisions. So if you have an acute injury and they get labs, like those are accurate labs. I don't want to give anybody impression that they're not. But we're talking about this wellness space and like something like a hormone lab. So it just depends on the test. Like if you're talking about thyroid testing, these are accurate labs. So these are okay. But like a hormone, estrogen levels, whew, no way. Like progesterone levels, testosterone. And we also have not really established this in the laboratory. And as I mentioned, all of the 3 hormones, just to confuse everybody more, they're in different units. Like estrogen's in picograms per milliliter. Progesterone, as I mentioned, is in nanograms per milliliter, and the testosterone's in a different one. So when you're comparing these numbers, it gives you this impression of like really strange impression because testosterone is actually higher than even the lab would suggest as well. So you really need to like we need to do better communicating. The laboratories need to do better communicating to physicians, and physicians they're just not. They don't have any training, so you have to go to a specialist that will also recognize that the labs have limitations. And this is key for women who they're thinking about it and they're going through it. Don't go to your OBGYN or your PCP. I wouldn't go to a dentist for back pain, right? Like if you need to go to a specialist that knows how to interpret labs or even just will listen to your experience more.
I'm sure, like me, you see women all the time who have bounced around multiple clinicians and they're having all these symptoms, and they'll come in pretty weary and probably quite irritable and kind of nearly expecting to be disappointed again because they keep being told it can't be your hormones because everything looks normal on your profile. Would you explain to the listeners why we can't diagnose looking at hormone profiles that you have perimenopause? Because I think so many patients and doctors find this really, really challenging. And I see so many women who they're just at the end of their tether. They have got the shopping list of 24 symptoms, but they keep being told, well, it can't be your hormones because they look normal.
I think women need to understand that it's partly because the doctors do not know how to correctly do hormone replacement therapy. I think so. They're also looking for an excuse not to do it. Oh, your labs are normal. So please leave my office. So, like, I don't know how to treat you. And instead of just saying, I don't know, go to a specialist, they give them the wrong information. The laboratories themselves do not flag abnormal levels. They don't actually, they say estrogen of 0 is normal. That's like a normal it's like, okay, again, we're like a decade behind the advancement of women's hormone replacement therapy. So Women are told that they're normal when they're not. That's the problem too, that you can have an estrogen level of 80 and they'll tell you that it's normal and that's low. So and then do you wanna feel normal for a 40-year-old? Or do you wanna have the levels of like a 28-year-old or a 30-year-old, right? Like, I wanna feel like a 40-year-old, but the way that the labs are reporting it, they expect me to be really low at 44, so they would tell me that I'm normal. So it's like women need to know, yeah, see that limitation themselves.
Can I ask you, whenever you hear women saying that menopause is natural and that, why would we be interfering with something that is natural? Also, there's definitely a cohort of women who I feel like it's nearly like a badge of honor that they don't take hormones if they kind of make it through and they don't take hormones. What would you say to people who say that? And also, where have we gone wrong that people feel like they have to kind of endure it and have that badge of honor that they did it naturally?
First of all, just because it's natural does not mean it's healthier or better necessarily. And so this process, again, bodies were not meant to age and like live till 90. I would argue that keeping your hormones at their natural level is actually more beneficial and better for you. And that's natural too. Like when you take bioidentical hormones, it's probably the most natural thing you can do. Taking herbs, like when women are like, "Oh, I took herbs and I didn't need any hormones." Herbs are not natural. We do not make chasteberry. We do not make ashwagandha. I do not make like turmeric. These are plants. They don't bind to the hormone receptors. They don't even modulate and manipulate our epigenetics. They do not protect my bones and heart and brain. And so I would argue that this is actually not natural and simply replacing the hormone, which your body knows exactly what to do with, is the most natural thing you can do. Growing older and I think that there's no badge of honor, and there is a few women that do it, but I actually wonder how well they feel, or if they're trying to, raw dog it and tell everybody that they're doing fine, and it's okay, like, it's your choice, but don't try to, like, say that it's like, more natural or better or anything like that, and then the women very much struggle more than, like, men. When I treat men, they don't seem to have as many severe symptoms, and women really, really do. We need to recognize how severe the symptoms are, and how debilitating. And if you have to quit your work early and all your relationships are ruined and you're like fighting this weight gain and you feel miserable, is that like a way to live the second half of your life, which should be amazing? Like, I want to have all the wisdom I have now at 44 and feel like I did at 25, right? I feel even better. This is the way to age, and we have this choice. And so when women are like, well, why, I don't know why they feel like that's some kind of thing to be proud of, because I don't know if you actually do feel that great. Like, you're the women that I know that are really trying to do it without hormones because they just haven't come to the acceptance that they need them. There's nothing like, again, you're not winning and your measurement of success is like doesn't, and so women will, their diet has to be absolutely perfect. If they stray from their diet at all, they'll feel miserable for days. They have to do like meditation and yoga and a lot of different things, therapy, and have a lot of toolkit for their mental health. They have to have like, they really have this like really strict regimen in order to go through this 20 years of their life without something like hormone replacement therapy. And so yes, you can do all of that, but, like, there's a shortcut, and I think for the most of us who are, like, normal and don't have all that time but I can still do cold plunges and, saunas and all amazing things for my body and peptides and go to sleep and keep my circadian rhythm and walk and exercise, but the beautiful thing about it is that if you just supplement and give your body this foundation that it needs, then it's like the shortcut because everything you do on top of that you'll get results. Like your skin and hair will look good, your bones will stay healthy, your diet and exercise is gonna work for you. I mean, if you're into, like, this natural thing, then hormones are part of that regimen, really. Like, it should actually be the women that want to take hormones are the ones that are into the natural thing.
Every day I hear women still have fear around breast cancer and HRT. And I wonder if you could address that ongoing concern. It seems it's a reputation that HRT just absolutely struggles to shrug off.
There's this saying by Mark Twain that, by the time the truth gets its shoes on, a lie can travel halfway around the world, right? And this is exactly what happened with HRT. The media picked up this really bad study that doctors believed it and patients and everybody overnight, like, stopped HRT, and now looking back, they're still cleaning up that study, which was, poorly interpreted and miswritten. And, we know that HRT likely doesn't increase your risk, but it likely protects against breast cancer. But let's just imagine a world like, let's just say that study was true. Okay. So let's just say, like, we'll look at that study and what caused all that fear. For starters, let's break this down. So, like, there is nothing in this world that is risk free. Literally, the most dangerous thing you can do is get in your car and get in the highway and like drive to the grocery store or whatever. So, and I'm not going to stop driving just because of that risk, right? Because of the benefits and the freedom and how I feel, like all the benefits of driving. I'm not going to give that up. So the benefits far outweigh the risk. Any therapy, any choice you make in life, you have to do this risk benefit analysis. And so literally nothing's risk free. And that goes for medicine and any therapy, even herbs that you take, some random herb that you bought off the internet, there could be a potential risk with that too, right? So you have no idea, like you have to think about this risk. And the risk from the study was there was one extra case in 10,000 women. Okay. So like 1 in 10,000 got an extra woman, like one woman got breast cancer and she didn't die from the breast cancer, but she got it. So 1 in 10,000 is extremely rare. That's like the same risk as getting hit by lightning. I just want to say that's like a lightning strike. Um, but when you look at risks of other diseases, 1 in 3, 1 in 3 women in the US die of heart disease. 1 in 3. So when you're talking about, but hormone replacement therapy, there is absolutely no question. There's nothing in the literature, like it protects against heart disease. Osteoporosis, like I don't know the actual risk, but osteoporosis, dementia. It's like when you start to need diapers when you're older, your world gets very small. If you have frequent UTIs as we get older, so these things are very common and the risks of these are high. Like if you're on chronic antibiotics for UTIs because your vaginal atrophy is so bad, there's great risk to that. If you fall and break a bone from osteoporosis and you're frail in your old age, that's people die from that all day long, right? So when you talk about how am I going to protect myself against these very common risks, hormone replacement therapy does that compared to this potentially very rare risk of getting breast cancer. I'll take that all day long. I will take HRT knowing that if my risk is 1 in 10,000, that benefit is way greater for me. Even if I have a family history, which family history is not a contraindication for hormone replacement therapy. So I don't know, like this reputation, women, and the problem, I think the thing is that women want to have control over this. They want to say that, hey, if I just avoid hormone replacement therapy, then I won't get breast cancer. Like if I just do that, so they feel like they have some kind of control over it, which you don't. There's chemicals in the environment. There's like plastics, pesticides, fragrances. These bind to the estrogen receptors. They cause breast cancer. Alcohol for every drink that you have increases your risk exponentially. Sitting is like the new smoking, right? So if you sit all day long and you don't exercise, you're at risk for breast cancer. These are the things that you potentially have control over and that you can do to mitigate your risk. But avoiding hormone replacement therapy, and then you think if I just avoid that, I won't get breast cancer, you're going to be surprised because it's not going to protect you. And then so, did you get breast cancer when you were younger, like when you were 15 and 16 when your estrogen was high? No. Did you get breast cancer when you were pregnant, when estrogen gets up to 40,000? No. So, why do you all of a sudden think that this hormone that's been protecting you literally your entire life is now all of a sudden dangerous and going to give you cancer at age 45? Like, it doesn't even make any sense, like, why we would even associate the two, even to begin with. So, again, and even if it does cause breast cancer, the risk, like you have to look at that risk benefit, and the benefit is way, way better. And that's how women really need to view everything anyway. And this is people, even women recovering from breast cancer, they should still be offered it if they're a candidate and they need to look at this risk benefit. Quality of life matters as we're aging too. It's not just about like trying to do everything you can to prevent breast cancer. Like, what if you're completely miserable? This is not a way to live either.
Yeah, absolutely. I've had a number of women who've um, been on treatment post breast cancer and they have had suicidal depression and they've made the call that their quality of life is so poor that they're just like, I have to make this choice that I'm going to start HRT because it is actually life or death. This is a real life or death situation. And it's a very personal decision, but I think we shouldn't be blanketly telling people no. So we've obviously talked a lot about progesterone. I'd love to talk a little bit more about estrogen. She gets a lot of chat about her, but tell me what you love about estrogen and what she does for us in our bodies.
They're, like, so amazingly protective, and as you know, it kinda segues into it, like, why we would I think it's one of the most devastating things we've done is to convince women that their very own hormone that makes them feminine is harmful to them. It's almost like we're telling women that something is wrong with them inherently. And I think women need to see it as for what it is, because we don't tell men that testosterone is bad. We don't tell men that testosterone is dangerous for them, even though can like risk. We used to it was like similar for prostate cancer, but we still like women. There's a very positive association with testosterone in men. We need to have that same positive association with women, that it's okay to be feminine, and like it gives us all our feminine features. It helps with skin and hair. Literally, it hydrates like our entire body. It helps with digestion, it helps with brain fog. And women that are, in this period of time where they're like not menopausal, but they're wanting a hormone, they're often sometimes only offered progesterone. So I know we talked about that, saying that it's ignored, but when they do consider it, they just leave it out. And like there's this really tendency to give women one hormone at a time. Like, okay, let's just bulldoze you with progesterone. That's it, because you're kind of making some estrogen. So we'll just give you the one. Women, like, are not really making that much estrogen in this time period, and when you try she needs both because they counterbalance literally, they counterbalance one another in the body. So, like, if women were to remember that even to maintain your blood pressure, you know, estrogen causes vasodilation of the blood vessel and progesterone constricts it, and together when they bind, they maintain this really perfect tone of the vasculature, keep your blood pressure steady, they keep you from getting headaches, they keep you from passing out, they keep you from getting heart disease, so they work together, and so estrogen is wildly beneficial for, even when you look at the immune system, progesterone is so protective against autoimmunity, but estrogen keeps us from getting sick. We need both. Like, when you think of them, they should almost be thought of together all the time. Like, essentially like this yin and yang, they're opposite of one another. They complement one another. They need to be in the right ratio for you to feel your best. And this is why we are literally more complicated than men. We're like a different species. Men, it's like, hey, you just need some testosterone, boom, you're done. Women, we really truly need like these three hormones in quite a bit of balance. So we need like them. Otherwise, if your estrogen's too high, then you're going to feel off. But we're talking like if women were like, if when we talked originally about what progesterone does, estrogen, women can think of it as like skin and hair and lips and wrinkle prevention and breasts maintaining their shape and the vaginal health and literally everything that makes us like feminine, like, beautiful skin and hair. Like, this is the things that estrogen provides us. And it helps keep our mental health too, like anxiety, the same things that anxiety, depression, and sleep are estrogen related. They help keep our metabolic fitness. Like, estrogen gets blamed for weight gain. Estrogen actually suppresses appetite and keeps us thin. Like, when you look at, just like when they show these like ripped guys for testosterone, they need to show like really fit women too. And this is like what estrogen provides you. And so that we can start making that association.
As someone who went straight from pregnant to menopausal very quickly, my skin really, really deteriorated quite rapidly. Now, I'd always had a sensitive skin, but my barrier function deteriorated and I developed really very obvious rosacea. And this is something that I see day after day in my clinic also. So many of you reached out and asked what I recommend and why. I have to say that since I opened my clinic, I've been using a brand called Rationale. They're an Australian brand that have been around for about 30 years. And what I absolutely love about Rationale is the products. They feel very luxurious, but they're extremely scientifically derived. And they've got these ingredients called skin identical formulations. All the ingredients, the minerals, the vitamins, everything that's included, the proteins, the lipids have all been found naturally within the human body, and therefore they're recognized by the body. So the ingredients are really, really well received. I find that menopausal skins and perimenopausal skins are dry, irritated, and sensitive. And with this range, I'm able to create a bespoke skincare plan for my patients. If you're interested in getting some of these amazing products, head to rationale.com and use the code YOU at checkout to receive some exciting bonus samples with your order. Can I ask you, what do you think about women who've had a hysterectomy who are only offered estrogen, estrogen only HRT, And, people will say things like, oh, that's great. You don't need progesterone then. What's your approach to that?
I kinda think it's like progesterone's not some kind of, like, weird sentence that you, like, have to take progesterone, it's like, okay, like, because I had a patient that was like, "Do I have to take this?" And I'm like, "You don't have to do anything." If you have a hysterectomy, what they tend to do is only offer you a tiny bit of estrogen. It's, like, literally a microdose, because if you were to take more, you would feel really unstable without the progesterone because, again, they really balance each other out, and so this is inappropriate and under treatment of women. Like, women need to see it as undertreating if you're only offered estrogen therapy. Very outdated. Um, I would be miserable if the women need, again, it's like we've associated progesterone with uterus and pregnancy, and it's only needed for that, and it's just so sad, like, to see that that's how we, like, literally talk about women and their main hormone, and we haven't studied it, and we have studied birth control to death. We have, like, thousands of papers probably on progestin, which is the fake hormone. It's not our real hormone, and we've studied that one a lot, but we have not really studied, like, the other one as much as we really need to be studying it. So, what I tell women is that you don't need to do it, but if you wanna sleep well and have great skin and hair and mood, you need the progesterone, like, you need them both. It's like building bones. Estrogen helps prevent the breakdown of the bone, and progesterone builds the bone, or it's the other way around, I can't but, like, they both together work to maintain the bone. So, it's like, yeah, I feel bad. I will never prescribe estrogen without the progesterone, even no matter what your uterus status is. If you come to me and you don't have your uterus or ovaries or it doesn't matter, like, you need progesterone for all these other reasons.
Yeah, absolutely. And in terms of a lot of the menopause societies and various groups still think that perimenopausal women should be offered the contraceptive pill instead of HRT. I would love to know what your take on that is.
That's very traditional, dogmatic. That's very traditional medicine, and, like, they're very old guard. The thought process is that if you have the capacity to get pregnant, we are not going to intervene. And this is really, really, like, sexist. We do not tell men that if you're making sperm, that we're going to leave you alone. And so this is the kind of the thought about women, and women should see it that way, that a lot of it's about control of women's bodies, but it's like, look, if you till your period stops for a year, birth control is your solution, and then we'll offer you HRT. But the FDA, like in the US, they basically say that birth control is contraindicated over the age of 35. Because of the risk of stroke, and if you have high blood pressure, and, so as you get older, birth control is actually not your best option, and it's not hormone replacement therapy. So I think women are catching on to this, that, 1, birth control doesn't work. It's not hormone replacement therapy. It does the opposite. Birth control is not a hormone. We call it that, just to, again, we need to muddy the waters more for women. But, we call it that, but it binds to it's a synthetic chemical. It's like fake chemical that's like we've made up. It's not found in nature, binds to the receptors and lowers your hormones to 0. So that estrogen, that little spike that you're making, that you is just like it lowers it to 0. Women's find there might be some stability. That's because you've stopped that roller coaster a little bit and they stop the period, but it's not doing you any favors, in terms of protecting you against long-term diseases. So this is really, I think, changing. There's a lot of doctors who are now saying that, "Yes, we'll treat you," but they'll only go down to, like, age 40. I think that really we need to be looking at, like, not age cutoffs, but what's happening to this woman and why, and it doesn't really matter how old she is, like, she should be offered some intervention if she wants it, and we don't have to impact fertility. I think that's what everybody's worried about, but birth control impacts fertility. Like, we have women that are on birth control and they can't get pregnant after. So I don't know why they think that's safer. Like, it's weird that, like, traditional doctors, and I think it's not weird, it's because they don't know. So if women can remember, again, they're not trained at all. They literally think that birth control is hormones, and they think it's a solution for all women's issues. They don't know there's another option. That's the problem. So women need to do their own research and find their own. Yes, absolutely. In fact, it's the best time to start, and I think that and because, like, when you think about, like, something like heart disease, it's hard to treat it. It's hard. My husband's a cardiologist. It's like you're treating it too late. You need to prevent heart disease, like, starting in your 30s. So the early like, hormones are, since they're foundational to health, they prevent disease. Like, they're not really a treatment. Like, we wouldn't really like, right now, they're being used as a treatment. Okay, you have hot flashes, you have vaginal dryness, you have this, like, we'll give you a treatment for menopause. We're treating menopause. Like, I just keep saying that because I want women to see that it's not actually the function of a hormone. Hormones are preventative. If we keep them at a certain level, they will protect and prevent disease. So a perimenopausal woman is perfect to get started. Like, we should be, like, preventing Alzheimer's and dementia. And even at night, like, for example, estrogen is thought to help clean the brain. We need cerebral spinal fluid to, like, remove all these plaques and buildup that happen during the daytime. And our brain is, like, cleaned and refreshed, and we need the presence of estrogen to do that. So if you start doing that at younger age, right, then you can imagine how much healthier your brain's gonna be as you get older. So yes, perimenopausal women, and perimenopause does not mean 30 and over. It means that you're struggling to make hormones is what it means. So we need to also stop with this age definitions that we have. Women are, like, being told that even 30 is too young. That's not true either. We're just seeing it younger and younger. And women, like, it's fine. We don't even need to call it perimenopause. We just need to say your ovaries are struggling. I'm sorry. It's okay. We have a solution for you. And getting started there's no shame in it. It means that you care enough to keep your body as healthy and as possible.
Sarah, I see a number of women who present and they will date the start of their symptoms to around the time of the birth of their last child. And I know that your story is perhaps a little bit similar to that. Can you explain a little bit about what's going on there?
Yeah, that's like, I mean, that's exactly what happened to me. I waited till I was 35. Like a lot of women are. They're, like, doing their career first, had a baby, and then the wheels fell off the bus, which I know they, like, do, but Uh, I didn't really feel like my hormones ever rebounded, and I don't think I'm alone. So, like, I think I was alone at the time. Like, I really we talk about hormones a lot now, but that was 10 years ago, and nobody was talking about it then. And I had no training in a medical school. We didn't have any training. I did not know what was actually happening, and I have the tools and the resources and the knowledge. I can imagine what, like, other women are actually struggling with, and now I hear it a lot, practically every day. The same story. That, yeah, it was my 2nd child, I was 38, and I never felt the same. Like, I just kept waiting. You kind of, like, sit around and kind of, "Oh, I'm just tired because of the baby. I hate my husband because of the baby." Or whatever. You're just never, like, fully recovered, and you don't feel like anything. Like, it's really you struggle, and this is the time where you're supposed to be, like, enjoying this baby and everything, and we don't talk about postpartum period enough. Women are left to suffer when you go to a doctor and you're like, "I have severe depression because of," like, and if you imagine, it makes sense because your hormone levels were, like, sky high and you felt great and your skin and hair looked great and you're like, "Yes, I'm rocking it," and then all of a sudden, bam, they're, like, 0 within, like, a month. We don't give women the tools. We don't, like, lead them on to this is what's gonna happen to them. It's all just like, "Baby, baby, baby," and then even when you take the women are left alone, like, they do not have the help. It's all for baby, I would say, and then, I just don't think women are getting that support, and they need to know, like, they're being offered the antidepressant, in this period of time. And hormone replacement therapy works within days. It's super fast for something like postpartum depression. And yeah, to answer your question, it's wild that, like, how many, and so they're actually probably perimenopausal. I like thinking back, I was perimenopausal before I had Ethan. We don't need a lot of hormone to get pregnant. We just need enough to get pregnant. And so, but I thinking back, I struggled for a long time, and I think women do recognize that they're struggling. They're struggling with fertility too. Like, so they're even struggling to get pregnant. And we tell women that, hey, you need to ovulate in order to make your hormones. The opposite is true as well. We need hormones in order to ovulate. So we need hormones in order to be fertile. So we see this, like, infertility. So they're even struggling to get pregnant, and then they get pregnant and they deliver, and then they continue to struggle. And we're not recognizing it. We're just like, oh, this is just the way it is. Like, this is part of being a mom. Exciting. Welcome to motherhood. Like, and so um I think this needs to stop, and we definitely need to be like, "Hey, it's not okay that you're, having these feelings and feeling depressed," and it looks like OCD too, like, that I don't think it goes unrecognized because women they're trying to, like, do what's right, so they it becomes looking like an OCD, which is actually a postpartum depression. So they just, like, look overly anxious about their child, and they're, like, doing a lot of things, right, and keeping a schedule, this really ridiculous schedule, and but they're masking this, like, feeling that they're losing control of their, whole life. But this is really, really unrecognized. We really gotta, yeah.
I have to admit, I was having a conversation a few years ago with Professor J. Ashry Kulkarni, and she's an amazing psychiatrist here in Australia who's very involved in the connection between hormones and women's mental health. And I have to admit, whenever she first said, well, doesn't it just make sense that in postnatal or postpartum depression that we would be using hormones? And I have to admit that I kind of went, wow, I felt really ashamed as a doctor that why have I never even questioned this? Why do we just jump straight to antidepressants? And why was no one ever going, well, this thing seems to happen repeatedly to all of these women or a high proportion of women after they've had a baby. What happens after a baby? You have a massive hormone drop. And yet no one ever thought it might be a good idea to give some hormones. I mean, it's kind of amazing, isn't it? I kind of was like, wow, I've really let people down here.
Women have not been treated appropriately for a long time. So, like, we're starting to discuss it and, like, talk about it, but it comes down to this, like, and it's really weird, like, and then women, I think, internalize that. They feel like, how come I'm so struggling so much? Like, I think I did, like, do I just not know how to do this mommy thing? Or, like, am I just not, like, figuring it out? Or, like, my friend's struggling as much as me? Or, like, I don't get it. And so I think women also go through that in their head, and then they also downplay it. So they're also trying to just literally, like, suffer in silence, I think is what's a lot of that's happening, and now if we were to able to kinda break that silence and just, like, talk about it and be like, "Hey, look, this is totally normal that you're experiencing this depression. It's not normal, it's not okay, right? It's normal." It's like we normalize it, and then we have a solution for you, and but you're right, it makes total sense because even antidepressants, they're not that successful. I think the statistics, they don't work that well. They don't work in everybody, and they also take weeks. Hormone replacement therapy, like, they'll feel better in days. Like, if they have postpartum depression, you give them estrogen, progesterone, they actually do start to feel that kind of inner calmness that they're losing their minds, and that starts to come back to them very quickly, and that's, like, incredible, like, nothing else, no pharmaceutical does that.
There's definitely a lot more conversations happening around the contraceptive pill. I think it's something that hasn't really been talked about or questioned in any capacity for a lot of years. Certainly in my career, it's just been, oh, that's what it is. You pop people on it, heavy periods, painful periods, acne, oh, PMDD, contraceptive pill, contraceptive pill. And it seems like people are really starting to question now, I suppose the long-term safety, what is the impact of maybe someone being on a contraceptive pill from they're 15 until they're 35. Is there any research or any thinking around that you could share with us, or where are we on that journey of knowledge?
I agree. Like, we're starting to recognize that we even just thinking about the birth control the wrong way. And it doesn't mean it's birth control is birth control. It's like good at what it does, and that's it. Like, if you can't get pregnant and the risk of pregnancy is greater than the benefit, then you're going to take the birth control. But if you're taking it for a heavy, painful period or acne or whatever, like, solution they're giving it out for, PCOS, PMDD. It's not a treatment. It shouldn't be a treatment for anything. And acts as a anti-fertility, like a hormone suppressing agent. It's not liberating them in that sense. It's certainly not liberating their health, but this is a really challenging because I do get that women need to take control of this too. So this is why I think it's difficult because I get that women can't get pregnant. They've been in situations where they can't. We need something better for women, I would say. I do like that, though, that we're recognizing that it shouldn't be a treatment. So if you don't necessarily need the birth control, then you shouldn't be on the birth control. Women do want to control their periods, for example, though. And so my solution that came out of my necessity here to feel better after my child is born is intended for, like, a younger woman. It's intended for somebody still menstruating that you could potentially control your period. So geniusly, if you think about it, like, we have no other way to do that. We do it with birth control now. And women do want to have control over this period too. So even if they're not worried about fertility, they're tired, they want to be able to at least control the period, and still have it because there's, like, evidence that we detox this way and it's fine. We need to have this period. The birth control discussion, I love it. I love that people are, like, recognizing how harmful it could be. Like, are we seeing the effects now? We see women who are potentially have endometriosis and PCOS where they put on birth control when they were 15, 16. I think so. Like, a lot of women have been on birth control for a decade, and now we're seeing the health consequences of that. So, it had its run, that we just gave it to everybody, but I think the second guessing the long-term consequence of that, are we protecting fertility? Are we protecting the brain? I would say no. Like, knowing what I know, I would absolutely never put my daughter I don't have a daughter, but if I did, she'd be like, "Definitely not." You'd have to try to find you just really, like yeah, there are other successful ways, to and your health is more important than well, it's the most important thing you have. And a relationship and partners should be, like, okay with that. That's the thing that I'm saying, that it's like your health is more important than, and a partner would understand that too.
Can we talk a little bit about, I know you've mentioned polycystic ovaries and endometriosis and even painful periods. I'd love to know how you approach these conditions, because obviously not with the contraceptive pill usually. So what how do you approach this and what's your thinking?
I think yeah, so if you look at PCOS, for example, this is like, women are being told that their symptom is the root cause. So they're basically being told that their weight gain is the reason why they have PCOS, and that if they were to just lose weight, then there would be no problem. And this is part of this, like, oh, it's like telling women, "Oh, you're the problem. This is a you problem. Like, if you could just do lose this weight, you would be fine." And this is just devastating to see because women are not gaining weight. Like, they're literally it's not that that's causing this problem. They're not growing hair on their face and having their hair fall out because they can't diet. Is like it's and then the traditional way is to give them birth control, which actually makes it worse because you're suppressing anything that they do have. And then you're putting them on metformin, which is another popular thing for PCOS, and metformin raises testosterone. It actually blocks the conversion from testosterone to estrogen, so you're raising the hormone that's giving them all the problems. And then you're telling them to eat a high fiber diet on top of that, and the fiber will actually make them worse as well. So, like, all the things that are making them worse is what we're telling them to do. And then endo, same thing, like, you give them birth control or surgery, and this population, both of these are they're completely ignored because they are being told that it's their fault or the women go undiagnosed with endometriosis for like 7 years, and it's because, "Oh, are you sure that period's that painful?" And this goes on for a long time, like, and then endo patients are just like, "Well, maybe does everybody have a painful, heavy period, or is it just me?" And so they do this for a while. They go to in and out of the ER. They're chronic pain patients, basically, and so the approach can be actually quite easy because if you naturally keep these hormones where they should be, then you can prevent all this pathology, pathophysiology in her. Again, this is another reason to start hormone replacement therapy. We talked about the postpartum period. We talked about perimenopause, right? This is just another reason it's looked different in you. I don't know why you ended up with endometriosis. Maybe it's your genetics. Maybe it's something else. It doesn't matter. It's nothing you did. It's not your fault, right? We can help you and like intervene in a way that you will feel better with a natural bioidentical hormone. So, starting to look at it differently is essential for women to be does that make sense? Like, we don't have to, keep telling them that there's no or wait for big pharma to develop some weird drug for endometriosis when we have a solution of just keeping her natural hormones appropriately balanced.
And so what do you mean by balancing your hormones? What does that actually mean?
One, it's mostly just keeping them in the right ratio and at the right levels. So balance is kind of overused, I think, because when in certain stages you can have a little bit you can be estrogen dominant, for example. PCOS, you can be testosterone dominant. And I'm not saying estrogen dominance means high estrogen by any means. It just means that it's like the only hormone there. So that would be an imbalance. If you have, even if it's a tiny bit of estrogen, if it's the only thing there, you're going to feel that. And so you need them not only to be at the right level, but you need them in the right ratio and this balance. So you don't want testosterone to be your highest hormone, or you're going to feel that. Like you're probably going to gain weight and get bloated and get hair on your face, like PCOS patient. Or if you have estrogen dominance, you're going to have your own symptoms. So you really want progesterone, which is the main hormone, to be the highest. And if it's not the highest in the women that feel fine and are healthy, progesterone is the highest, is my argument. So like in endometriosis and PCOS and perimenopause and women that don't feel well, their progesterone is like way low. And so their estrogen, might be normal or not or whatever, or testosterone too, but everything's off because the progesterone is off.
And so are you approaching that in a really bespoke manner in that, like, patient A and patient B and patient C who might all have PCOS or might all have endometriosis are having a completely different recipe or prescription of hormones.
For whoever's listening, there's no lab test, there's no magic crystal ball, there's nothing that's gonna tell any doctor what's right for you. Doctors are literally like they have their way of doing it, and that's what they're gonna do. We have to start thinking about, you're here at 0, we know that you're struggling. Let's get you up a little bit higher, help with some of your symptoms, and then once you give me feedback about how you're doing, we can make some adjustments and changes. There's, nothing in that, like, I get this question literally all the time. And hormone replacement therapy, why is it expected to be so different than nothing in medicine's personalized? We literally have like the same set doses for like everybody, And then even the patch and the pill and the low dose vaginal cream, those are not customizable. Like those are literally the same dose. You're going to take 200 milligrams of oral progesterone and you're like on your way. Like men, they get the exact same dose of testosterone. Exactly. There's no like, and you basically start them at the same dose. You can kind of tailor it like as you go, but depending upon how they do. So this idea that you get 0.25 milligrams and you get zero point 0.3 milligrams and you get point like that doesn't it's pointless because you're not going to make that big of an impact by like manipulating it that much, right? Like so women need to kind of get out of their head that that's even going to make a difference for them, but then also that when trying to chase one hormone at a time is exhausting, it's expensive and it doesn't work. And then also that your journey is going to be completely different. So, like, yours is gonna look different than a PCOS patient, and even between PCOS patients, it'll look different. But there's a lot of similarities, and we can predict a lot, right? So there are, like, some nuances and things that we can hold on to, like clinical pearls. But in general, it's your experience that we need to like, if I put you on hormone replacement therapy and you get, like, water retention and you don't feel well and you even get, like, really irritable, but your best friend does really great on almost the exact same thing. What do we need to do for you? Like, if there's something going on with your health that we need to address, and that's what makes it personalized. Like, women need to see that their journey, like, is going to potentially need something else. Like, if my uterus isn't as healthy as yours and I have a lot more bleeding, then we need to address that. Like, if I have major iodine deficiency or some other mineral deficiencies, then we need to address that. You don't just think that like, "Oh, I'm gonna start HRT and be magically better," and you're gonna get the dose right. And if you don't get the dose right, then you're a terrible doctor. Or, like this is not the appropriate way to think about hormone replacement therapy. You need to be thinking about it as I'm going to try like to get started on it, raise everything, and then see like if some underlying problems pop up that I need to address. Is my gut health that bad that I really need to like work on that? Is my gallbladder health? And so if women realize that feeling better doesn't about chasing doses and lab values, that it's about like looking at the body holistically, looking at what's going on elsewhere, they would have a better, like, more realistic experience about HRT too. Because I think women are just like, "Oh, this is not I'm not a different person. It's 3 weeks. Like, I'm just like, done with this," right? So, it's not that's not what hormone replacement therapy is. Like, you're trying to get foundational health, and it's a journey. It's literally like a lifelong journey sometimes, but you should that first 6 months is critical at making sure that you do we do have it right. And so, yeah, you do need to make changes sometimes depending upon how you do. But that starting dose is not like you can't predict a starting dose generally, right? Like, so you can yeah, so I shaking your head because I think women are like, "Well, how do you know what to give me? Like, how come, like, Mary gets this and I get that or whatever?" And they just need to dive in and start it, and sometimes they do have to try multiple things, right? And that's okay, like, HRT is not one size fits all, I'm not saying that it is at all, but what works for someone else may not work for you, and some things can be tweaked. Like if you start my product, which we don't put any testosterone in it, for example, but it raises it to like a normal, let's say 30 is normal, and that's kind of where the cream gets it. But you want to be a little bit higher for whatever reason. I don't really care. It's fine. It's your choice. So like let's say you want to be higher on testosterone, you could tweak it. Like you're like, okay, how do we get you a little bit higher because you're gonna feel better and you want more libido than Mary, and that's okay. So and I think that that needs to be recognized that testosterone could be that some women don't want it high. Like, this is very individualized. Some women want it lower and they feel better and they feel a little bit irritable when it's too high. Some women gain weight when it's too high, and so and then some women feel like really mentally slow and no libido when the testosterone is too low. So this could be a hormone that you could really dive in and optimize for every single woman. This is something that really probably needs to be individualized very much. But it also doesn't mean to be like the first thing that we optimize. So like I think the approach that we take with women needs to be thoughtful too. Um And as long as you're doing that, like, and you're working with her and you, like, tell her what's gonna happen, like, if we estrogen, progesterone are the main hormones, like, that should be our focus first. Like, if can we get those right first? And then we'll work on testosterone because it's actually the easiest and we can kinda see that libido and we can make sure that it has happening or whatever, but the other 2 are the hard ones. Let's get those first, and women generally are very receptive to that. It makes sense. And your journey is gonna be different based on your physician and their experience for sure.
I agree. I always work on estrogen and progesterone first, but I have had a couple of people, interestingly, recently who are on testosterone as well. And when they have come in and they've been very excited, they're like, "This is the best I've felt in 20 years. I feel amazing. I'm bouncing out of bed. I'm exercising." And then I've sent them off to the lab to check some levels, and the testosterone has been quite high, like outside the normal range. And, I'm not going to lie, I've kind of freaked out and went, oh my gosh, we have to like reduce the dose. And they're really disappointed because whenever you take it away and try and reduce the dose down to get them into sort of a more normal range, they just don't feel as good. And I always think, gosh, I wonder, did this person naturally, when they were younger, did they always have quite a high level? And we're trying to put everyone into a box or a range. But what we don't know is, maybe this person had a high testosterone always. So it's just quite interesting. Some people are like, please don't take it away.
I love that you pointed out, like, it's inappropriate for us to be forcing them into a reference range that may not be appropriate for them. Like, we're forcing them into this range that, like, has probably been only established on, like, 50 women, and then we don't know if that's true for them, and then also, who am I to say that it's high? So that's another thing too that, like, it's not my, like, I don't, like, say that, "Oh, no, that it's weird that we would even kind of do that to somebody and say, okay, well, that's how you feel your best, so that's not high for you, that's just what you are." What really can tell us what's high is the brain. Like, FSH will tell us, like, if we're suppressing FSH too much, then the brain will be like, "Wow, you're giving me too much hormone." That would be like, "Okay, we're doing it. We're overdoing it a bit." But other than that, like, these absolute levels, you're right, like, women need to tell us, like, they need to be like, I felt way better when I was this level. Or because if you've done no good to them, if you force them into these reference ranges and then they're still sitting in front of you telling you that they feel terrible, you're not done like your job because like your labs could be normal all day long. So completely agree with you. This is like we can use them for guidance. Like especially if something's going not wrong with like if they're not struggling, like if they're struggling and you're kind of trying to figure out the laboratory testing could be guidance, but they shouldn't be like everything. Like they might help confirm your clinical judgment. Like if you're like, let's get a test and then it kind of confirms like what you're thinking, that's helpful. But otherwise, yeah, you're not gonna sometimes you don't even catch, like, these higher levels too. They'll have, like, hair on their face and the testosterone will come back normal, and you're like, "Okay, I don't know," like,
Yeah, I know it's a
um
bit strange. I think it's interesting though as a doctor because you're always worried about, I suppose, getting litigated against or getting into trouble or acting differently than your peers and all that kind of stuff. Are you going to be judged? But it is very hard when someone's telling you that they feel incredible and they're just living their best life and you're like, oh well, can I just take some of that dose away from you? It's very challenging.
Yeah, and I think that this is kind of an imaginary fear that doctors have. So, like, I think that I'll talk to doctors and they're like, "Well, I'm afraid of," and you're like, what is the litigation here that like them feeling great? And it's really, I think the hormone, there is this weird fear that doctors have. But they're also practicing a lot of defensive medicine. Part of it, like if doctors understood it more, they also wouldn't get defensive. Don't you agree? Because they would trust their own skill set. Yeah, I think it's when they don't know what they're doing, they get a little bit like worried about it.
Sarah, I wanted to ask you about a group of women who comment all the time on our podcasts, and they are that group of women probably in their 60s and 70s, and they're that generation who absolutely, unfortunately, missed out on HRT. And I will put my hand up. I worked in the UK. We were pretty much told we weren't really allowed to prescribe it. Everyone had to come off it. And so there's this group of women who are intelligent and they're hearing everyone talking about HRT and they're feeling like they've horribly missed out. So what is your take on when is too old to start? How do you approach it as someone who comes and they're 63 or they're 83 or, it's probably the most common question I get asked. And I definitely see a full remit of women from, in their 20s right up to their late 80s, I think is the oldest person that I've seen who has wanted hormones. And I would love to know what your approach to this is.
Yeah, I think that there is some new literature that's showing that the benefits outweigh the risks. So, getting started, like if you're were to prevent UTIs and bone fractures and in this population, that's great. Like they should be offered it. I think some options are better than others. Like, I have started older women on it and starting low and slow and and then the risk really is that for your listeners, it's like if you've gone a long time without hormones, your arteries can come stiff and then you introduce the hormone and they could become pliable and you could like what if there's some plaque there that I think that's like what everybody's kind of worried about. And to mitigate this risk for that age group, a cream is probably like a really good choice because you're using creams instead of like an oral estrogen or something like that. And so that can help. And then also just like making sure that they start a little bit lower and then they understand that there could be bleeding risks and things. But I have a cutoff online just because it's so hard to treat, online already. And so since I'm telemedicine only, don't take older women, but it's not because I'm ageist or I don't think that they deserve it. I just think it's better that they would get it from a clinician who can maybe tailor and do this probably more tailored approach for this population. Like we need to do just a tiny bit of this and a little bit more of this, and this is fine for them. I think that's actually very appropriate, and using clinical judgment and then having a discussion with the patient is really important. Whereas a younger woman where her risks are lower and, so this, I think it's totally fine that they in my opinion, that they get started if they work with a provider that really is, like, okay with it and can do it and use the right formulations. I think the formulation really matters. I don't personally start them over the age of, like, 63.
Right, okay. And in terms of what does this word body identical mean or bioidentical? What does that even mean?
It's such a great question. It's just like a marketing term. It's like something that really came out about after that study that I think when people like doctors who really knew the difference, they could see that was really wrong. They knew that this, since the difference between conjugated estrogens and progestin, and they knew that there was a difference in outcomes with the bioidentical potentially. And so we started calling it bioidentical to distinguish that, to say like, hey, these match what your body makes, exactly what your body's making. It's gonna bind to the receptor in the same way, and then hopefully we'll get the same results, and then we'll get a better, like, clinical outcome, like, you'll feel better, you'll feel more like yourself. Whereas a synthetic is something that's been chemically modified, right? So you can actually have a synthetic bioidentical, but we don't need to get into that, but it's just more like we're just trying to distinguish so that you know that what we're giving you is, like, what your body makes versus something that, like, it comes from a different chemical that's not found in nature. That would be like a synthetic that we do, and now we give those in birth control. We give them, I think I think most providers now are using bioidentical is from what I understand. There's a lot of pivot towards that.
Yeah, absolutely. And probably like me, you see a lot of women come in really upset about their weight and feeling not confident. They don't recognize their body anymore. And they're really frustrated because they're like, I'm still eating the same way. I'm going to the gym. I'm doing the strength training. I'm doing reformer Pilates. I'm walking with my friends 3 days a week. And I'm just putting on more and more weight. Can you give us some of your insights into how to approach this?
Yeah, I think women need to also be thinking about hormones because they help us maintain our metabolic fitness and the flexibility. Like, how come I could eat pizza at 20 and I can't eat it now? And so this metabolic flexibility has been lost. And GLP-1, as we know from all the fancy injections, I'm sure you guys have them too. We definitely have them here. And so GLP-1, we've learned from all of this that this is what's missing or that we're maybe not making as we get older. And that the Ozempic and Mounjaro, they replace it. It's a synthetic version. It replaces it. But if you want to try to boost it naturally, estrogen does that. Estrogen will raise GLP-1. It helps modulate it. If you do it in conjunction with an injection, you get a synergistic effect. You get a better effect with the two together. But there comes a time where you've lost it. So if in again, that's why you got to start in perimenopause. Like you got to start earlier because then you could try to prevent the loss of even GLP-1 and your leptin pathways, and you can maintain your weight. Then it's much easier than trying to lose it later. But if you're kind of older and you've lost this, and you try hormone replacement therapy to try to get this back. And sometimes it will work, but you can also use like something as a boost. But I think women need to remember that what I think is so disappointing is that we use health as a measurement of, or we use weight loss as a measurement of success when health should be our measurement of success. So when you're looking at hormone replacement therapy, weight should not be like, women are like, it's been 4 weeks. Why haven't I lost any weight? And it's like, okay. So first of all, you're not going to lose weight. Nobody's losing weight in 4 weeks, and it's going to take 10 months at least and 12 months. So get like expectations in line with what's really going to happen with your body in terms of hormone replacement therapy. But I think that you want to, if you're sleeping, you have less cravings for food, you have the energy to work out more, you feel better, like your mental health, those are measurements of success that will translate into weight loss. So then you're gonna be more successful with your weight loss efforts. So we should never use weight loss as our measurement. It should always be health. And then you win. If you use weight loss as a measurement of success, nobody wins. But if you use health, then you win both. You get health and weight loss. And so this is also important because women have been told like our whole lives that we need to be smaller, and then we need to start like fasting, for example, like we need to be fasting. Most women fast to lose weight, and we shouldn't be fasting. I think that like women need like stable blood glucose levels. And if we looked at food differently, and there's a lot of things here that we can unpack, we probably like, but I agree with you that weight loss is on everybody's mind, but you shouldn't wait until the weight gain happens. Like try to look at these early signs that we talked about maybe anxiety and depression, irritability, insomnia, even just like pay attention. Like you need to make the connection between your vagina and your brain. Like if you're getting brain fog and vaginal dryness or like low libido, act on those first. It's almost like they come before the weight gain. I don't know if you've seen, but it's like if you're waiting until you have a hard time losing weight, you've almost kind of waited too long and it's harder. So just that's why it's so important to kind of recognize it early, get on them early, and then the weight gain isn't.
I find an early symptom is definitely irritability, and irritability with partner, and probably frustration with children that maybe people haven't felt before. Is that the same as you're seeing?
Totally. Like, and then we were like, it's not, oh, we can't do anything about your husband. Maybe your husband is like upsetting you, but like we can, but generally I think it's true. Like they'll come into my office and they're like, I don't know why I hate him. Like he's a great guy, but like I hate him. And it's like this, they recognize that it's a problem, or they're very short-tempered with their kids, or they're like, I'm slamming kitchen cupboards and I don't know why, like I can't control it. And I just feel this like really on edge, and my family is great. And this is disturbing to women because they don't want to hurt their relationships. So this is such a sign that you need to be on top of it because it does get worse. And this just continues to get worse, and women get divorced, right? So this leads into divorce. It leads to infidelity in the partner because you're not, it's like this is a real problem for couples. And so recognize, yeah, absolutely, it's not. And they're blaming. I think that's also where you start blaming. Oh, my kids are just like super annoying, or my husband is just like not doing X, Y, Z in the house. And instead of just recognizing your own tolerance is really declining. If you think about pregnant women, like when you see them, they're like one of the most chill people on the planet. It's literally like nature's Xanax. It's progesterone is nature's Xanax. It binds to GABA receptors and so do the metabolites, and it keeps women to tolerate small children around them as well as being pregnant. Can this state of pregnancy? So it is nature's way of keeping women tolerant of men and small children.
I had a patient yesterday, and it was funny because it certainly struck home, but she said that she'd made her husband move to the spare room because she believed that it was his snoring that was keeping her awake. And she just said she was like so angry with him about his snoring. But then she said he moved to the spare room, and she continued not to sleep. So she realized that it wasn't really his snoring that was that was the
It's
problem.
so funny. It's so classic. Like yeah, at least she figured it out that it wasn't him. Yeah.
Yeah, absolutely. So what do you see happening next? What do you think is going to happen? I mean, we're seeing all this explosion of doctors talking more about perimenopause and menopause on social media. We're seeing interest from governments about trying to put some things in place for women in the workplace, et cetera, et cetera. But what do you think is going to happen next, or what do you think the big, exciting evolutions are going to be in this space?
I think it's a super exciting time. Like that women are, and they should continue to keep voicing this and fighting for it. And doctors I think there'll always be, like, specialists, and women need to go to the specialists. I don't think we're gonna see, like, this training in medical school, and menopause isn't even recognized as, like, a specialty. There's no board certification for, like, hormone replacement. It's like but it should be. It's like its own thing, its own whole body approach, as you know. It's like but it's not even recognized, like, as a thing, by, like so I don't see that happening anytime soon, but what I see is the specialists getting better, more of them coming about, more longevity, anti-aging, and hormone replacement specialists, more menopause specialists, and doing it better. And that we're and that it, the cl- like I've already seen it over the last year that I used to have a lot of women come to me and be like, I'm worried about the breast cancer. I'm worried about breast cancer. That's like almost seems less and less. Like they almost know when you get on the social platforms and somebody says this causes breast cancer, you see like 10 people get in there and be like, that's false information. It's not. And so that was really exciting to see over the last like even just year that changing. And then, the exciting thing is that, like, our daughters, like, I don't have one, but, like, they don't have to go through it, right? So each generation will start to recognize it earlier, see it, and not fear it. Instead of fearing the hormones, we can understand them more. We need to and I think the studies will come about for endometriosis patients and PCOS patients who will get to study these reference intervals, like, for progesterone and estrogen and nail them down more. And what we say is high is not necessarily high, for example. So we did this for men too. We kind of forced them into lower reference intervals at first. We were like, "Oh, you should be between 4 and 800." And now we have expanded that to be like, you should be more, even 1500. Some women feel better at that. So we're more accepting of this variation that you're talking about. Like, well, maybe you do feel better higher and that's okay. And so this is changing. So the specialists are getting even getting better. And women are like, the exciting thing is that women are really searching for it and asking for it and not taking this for an answer like, "Oh, you just told me my labs are normal." They're actually searching out multiple doctors, and this is I think we saw like, what was it? Like 6 in the US, we had 6 million women on HRT, and then that study came out, and there was, like, nobody on it, and now it will slowly creep back up to that, and there's 70 m it's like 70 million women that need it in the US alone. That's worldwide, right? Half the population. So, hopefully, we'll see more women on it, I think. I really do think that it's one of the most beneficial, protective, preventative things that we can do. We would save healthcare costs, like, downstream if we put women on it, and so it is cool to see that women could be on it earlier and there wouldn't be a shame. Like, we could remove the shame around it for women. We could remove shame in aging and start just being like, "Hey, it's actually a something to aspire to." Like, being on hormone replacement therapy is not secretive or shaming or something for menopause. It's actually, like, something you do pretty early and you're excited about it and you're telling your friends about it. That would be cool, right? Because it's yeah, like, you can all share in this experience of being healthy.
So cool. It's going to get there. Would you be happy to share with us, as someone who's got an interest in hormone health and longevity, what supplements or extras do you take or do you recommend to your patients?
So I am like a big fan of iodine just because I see so many women have iodine deficiency. And like when we give the liver so much credit for detoxing, right? These pathways. But yet nobody recognizes how much the breasts and uterus actually remove estrogen from, like, the body. And so if you don't have iodine present, though, iodine is what helps the breast and the uterus remove estrogen, then you get fibrocystic breast disease, you get density in the breast, you get cysts, you get pain, and this amplifies during hormone replacement therapy, virtually with any formulation, like or if you're doing it, like, right, you're definitely gonna get breast pain. And so even progesterone alone will cause this. And so this iodine, if women that they're being told there's this like kind of myth online that iodine's dangerous or that iodine is going to give them their thyroid problems. But there's more receptors in the breast and uterus than in the thyroid for iodine. And so are we missing fibroids and problems because women are so iodine deficient? Are we doing something so basic as missing a nutrition deficiency in women? And so this is like if women understood and then everybody's afraid to start it, like, at least here, like, endocrinologists are like, "Don't do iodine." Like, why would you not do a nutrient that's like fat? We probably our ancestors found it in the water. And then there is this fear of thyroid stuff, but if women understood that fluoride and bromide are very toxic, and they're found in the food, they're found in the water. Fluoride's in the water, and it's toxic, and they bind to the iodine receptor, and when you introduce iodine into the body, it bumps fluoride and bromide off, and you get this detox reaction. You get, like, rashes, fatigue, headache. You get, like, a pretty nasty sometimes women feel pretty bad when they start iodine, fatigue especially. And if they recognize that it's going to be like a week of pretty miserable feelings because you're trying to get this bromide and fluoride out of the body, then I think iodine would be less feared. I think this is what everybody's fearing is this week of detox, but and then they're blaming iodine or something, but iodine is, like, one of the most essential things that women need that I don't see that men need. I don't know if they don't have babies, so they don't have like, but iodine, I would say, is critical, and then I really like green tea extract because the chemical has been found to be toxic against ovarian cancer cells and breast cancer cells as well. So, like, women who drink green tea every day are 80% less likely to have ovarian cancer, for example. So, something that's so toxic and easy to take on a daily basis to keep you healthy, and potentially prevent cancer, I think is amazing. And then I also really like berberine. So, I think this is a supplement that I've never had a woman complain about. They love it. Um, it raises the AMPK, balances the microbiome, raises GLP-1. It's like helps them suppress appetite if they are trying to, with some of these cravings and losing weight. And so berberine has been mostly well tolerated, I think, by women, and it does help balance some hormones as well. But these would be like three, there's probably a lot, but I kind of think women should also be like, hey, again, if your foundation's hormone replacement therapy, then a few supplements here and there, but iodine's like almost a must if you're going to do HRT.
Okay. Okay, that's really interesting. I have a feeling that here in Australia, there's added iodine in flour. Would that be right? I think there's some kind of iodine supplement that happens here at source, but
They ended up adding it here to, like, salts, but the problem is it's, like, not enough iodine, and so when you look at, like, at least for our risk guidelines, we have it's, like, 75 micrograms in the supplement, which is so low, and then women are like, "Well, I am taking it every day." And you're like, "Great, that's good for your thyroid," but, like, for your breasts, like, need a lot more than that, and I think it's because we breastfeed, so we have all these iodine receptors too, and maybe we need to give iodine to the baby, like, there's a breast surgeon that's really smart, and she wrote the book called Iodine Crisis, and she talks about how it could potentially be increasing your risk for breast cancer. It's an excellent book because she talks about how the glands in the breast will become abnormal, that they change in the absence of iodine, and then that dysplasia could turn into breast cancer. So it's like, are we this would be a critical nutrient then that women needs for breast health and uterine health too, and ovarian health. Like women, it's almost like we talked about hysterectomies earlier. It's like we're ignoring breast health, and I'm not saying we're ignoring it, but we're missing some basic stuff here for uterine, ovarian, and breast health for women.
Sarah, it has been amazing talking to you. I have used up so much of your time already, and I definitely want to talk to you again. I would love to finish by asking you one question that I ask all of my guests. If you could give 20-something Sarah a piece of advice, what would you tell her?
I would tell her you needed hormone replacement therapy, girl, when you were like 20 in your 20s for sure. Like, I did engineering school and then medical school, and you like burn out. And I think I would have enjoyed like my 20s a lot more had I had the support that I have now. And so I would have probably taken a lot better care of myself in terms of like diet and started and not been so even myself was like, you just that would have been amazing. That's what I would have told her. But I also would have been like, yeah, super proud of her. Like this, it's something that we don't tell ourselves enough, like that we do great things, like we really do. And I tell my kid every night before bed, and we need to tell ourselves that too. But I would definitely tell my 20-year-old self, like, how proud I am of her.
Oh, I love that. I love that. No one has ever said that, but I absolutely love that. Thank you so much. That has been amazing. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.